We're going to take your questions. If you have any that you want to ask, you raise your hands. We have your forms here. Thank you very much. And the first question to Stuart. Primary care is key to reform. What do you think are the right mechanisms to increase the number of primary care physicians to meet the need?
First of all, are there any primary care physicians in the audience?
It's way back.
You are an endangered species. We want immediate protection for you because there are too few of you. We have a great healthcare system, but it's not perfect. And, over time, we've allowed, for a variety of reasons, the percentage of our physicians who are not primary care to sort of grow to levels where we've gotten distorted. We need a better balance. For certain things, specialists are the key. But we need a balance between primary, and we've gotten out of balance. The fact that less than 15% of new entrants to the medical community are picking primary care. Now, why do they do it? First of all, they're underpaid. The way we've structured our payment system underpays primary care relative to specialty care. Second, actually, it turns out to be a very hard job. So, two things. First of all, we need to change the payment structure. Second, we need to recognize this is a team sport. With all due respect to the physicians, I don't care. We're not going to be able to train enough primary care physicians. We need to develop team efforts. There are other people on the team. You talked about it. Nurse practitioners, physician extenders, and the like. The doctors need to be the captains of the team, but they don't need to be doing all of it. So if we don't change the way we practice medicine at the primary care level, this problem is going to get worse and worse and worse. We've been attacked here in Massachusetts because while we were so successful in passing healthcare reform, we've made our primary care problem worse. And if you move out of Massachusetts, it even gets worse. So what Paul said is absolutely right. This is a team sport. And more of the medical community, particularly the physicians, need to behave like they're part of a team.
What about the idea this person has here of paying for their education, increasing their salaries, those kinds of ideas?
Well, as I said, in the healthcare reform, as part of that 2,000 pages, there is a somewhat of an increase in the payment for primary care. There's a new concept. It's called the medical home, where you pay for people who actually worry about us as patients. Not only about our medical conditions, about how's life at home, all the other problems that influence. So we need to pay more. And as I said, the healthcare reform moves in that direction. It doesn't go far enough, but it's moving in the right direction. And in fact, you're right. There is in that bill more payments for individuals who are willing to go into primary care to have their education paid for, and in what we call graduate medical education. So yes, it's in the bill. It's moving in the right direction. I think we need to do a lot more of it.
Okay. We also have people out with microphones in the audience. If anybody wants to speak that way, we can do that. And while we are looking for hands to be raised, here is another question. I think this could be asked to the three of you. There is a perception held by some that because Massachusetts has gone through statewide health care reform, somehow it will be hurt by national health care reform. Any thoughts on that?
In general, most of the points that are part of Massachusetts bill will stay in place. Also, the bill has some special support for the state of Massachusetts. There are some issues about penalties and incentives that will go. But I think the important thing to realize is the Massachusetts bill did one thing. It covered uninsured people. It didn't deal with Medicare. It didn't deal with cost containment. Some provisions in that bill may hurt hospitals or physicians in the state of Massachusetts. It's not related to the Massachusetts bill. It's related to that. So the larger bill is larger scale. There was a huge amount of effort not to hurt Massachusetts, both for Senator Kennedy, his legacy, and for Senator Kerry, making it very, very clear the purpose of this is not to take the model and do it in. But there are some features of the bill that will be difficult for some hospitals or physicians. But the basic essence of the Rest Massachusetts bill will remain.
On that front, I think we should especially thank Senator Kerry for his efforts on that front, and also Congressman Capuano on the House side really paid attention to potential effects on Massachusetts and got some protections in there for us. The Mass Hospital Association recently sent out a notice to all of the hospitals saying, here's what you can expect under the bill in terms of Medicare reductions and the like, and here's what your doctors can expect as well. And they were big numbers. But included in those numbers were the annual reduction in Medicare rates that are expected to be applied to doctors, which every single year do not go into place because Congress reverses that. This is where the politics really comes to play over the next 4 or 5 years, because I think it's important to remember that across the country, the local hospital in virtually every congressional district is not only the local hospital, but it's also very often the largest employer in those districts. And the idea that Congress would each year take an action to undermine the financial viability of the local hospital and the doctors working there is politically unrealistic. So I think a lot of the projections about negative impacts on Medicare rates are likely to get undone over time, my guess.
Question that kind of follows up. Will Medicare exist in 2029?
Absolutely.
Yeah, but I think it will be.
I'm sorry?
I said absolutely. I'm going to be there, and I'm going to make sure that happens.
I agree with that, but I think the other thing that's going to be here will be a national value-added tax to pay for this new entitlement program. I think that's the unstated part of this legislation. People in the administration were quietly talking about that, saying that although the bill gets put off for 4, 5, 6 years, when the full cost comes in, there will have to be a tax increase to pay for it, unless we get really, really good at controlling healthcare costs, and nobody thinks we're going to get that good at it.
I think, in my experience, Medicare is among, if not the best, health program that the federal government has ever passed. It's not perfect. We are seeing those of us who have higher incomes are being asked to pay more for Medicare. Both Part B is income related. Increasingly Part D, the prescription drugs, is going to be income related. But Medicare will continue. And the people who scare seniors and others are doing it often for political reasons. And it really bothers me a lot, because they're the same people, the people that argue for death panels, are the same people that don't want to fund the Medicare program. And I'm going, whoa. We should talk about things like comparative effectiveness and death panels, because Medicare needs to be a better program. By that it means it needs to pay for things that work, and it doesn't need to pay for things that don't work, so that we can make sure that it survives. And that's why the Obama administration is spending over $1 billion on doing research to find out which of the procedures that we have out there really work, which of the drugs really work. So if we do the right thing, and I'm with Paul, when all gets said and done, we need to find more money for Medicare. And you know what? I think Americans are going to step up to the plate and pay for it.
Bob, any thoughts on